Hi everyone, thank you very much for joining us today for an exciting live webinar entitled Photoacoustic Imaging of Tumor Oxygenation, Validation with MRI. Today's speaker is Laurie Rich. Laurie was an undergraduate. As an undergrad, Laurie attended Hiram College, where in May of 2012 he obtained a BA in biochemistry. Currently, he is a fourth-year PhD candidate in the Molecular and Cellular Biophysics and Biochemistry program at Roswell Park Cancer Institute, where he works in the laboratory of Dr. Mukund Seshadri. He has developed a broad background in biochemistry and cell biology with more recent training in medical imaging technologies and image analysis techniques. His thesis project focuses on utilizing photoacoustic imaging in head and neck cancer. Specifically, he focuses on the prognostic utility of photoacoustic imaging-based tumor oxygen saturation measurements for monitoring the response of head and neck squamous cell carcinoma to chemoradiation. Within his first 3 years in Dr. Seshadri's lab, he has published 3 first-author publications related to his thesis work. Laurie will actually be defending his PhD thesis in just 2 short weeks, so I hope he doesn't mind me saying no holds bars with the questions. It'll all be good practice for him. So on that note, I'd like to pass things over to Laurie for his presentation today.
Hello everyone. Thank you, Christina. I'd like to thank Fujifilm Digital Sonics for giving me the opportunity to present today, and everyone for showing up. Just to start out, I'd like to say I work in the Department of Cell Stress Biology and Pharmacology and Therapeutics at Roswell Park Cancer Institute in Buffalo, New York. My advisor is Dr. Mukund Seshadri, who unfortunately could not make it today. But I did include his email address on the last slide just in case anyone is interested in reaching out to him with any questions or comments. So first, just disclosures. Unfortunately, there are none. And so these are kind of the talking points that I included for this webinar, and we're going to be going through each one of them. So just to start, I want to give a brief overview of photoacoustic imaging and its potential for monitoring tumor oxygenation. But before I do that, I'm not sure what the background of everyone is in terms of cancer biology, so I just wanted to give a quick kind of overview of why do we care about tumor oxygenation and what are its implications in cancer biology. So what you see here on the left, this is a diagram showing what normal vasculature, as sure many of you know, what it looks like. So it's very organized, it's hierarchical, so we have arteries with capillaries and veins taking away spent blood, and it's evenly distributed. Unfortunately, when you look at tumor vasculature, it doesn't look anything like that. It's very chaotic. And what I mean by this is you actually have some vessels which go nowhere. You have some vessels which kind of loop around, so blood flow isn't very effective or efficient. And you also have very leaky vasculature. So unlike normal vessels which are very well covered in pericytes, these vessels do not have very good pericyte coverage, so things leak out of them very easily. And what commonly happens is as the tumor grows, it usually grows beyond the means of the blood supply. So what happens is we have diffusion limits to how far oxygen can diffuse from the vessel into the tumor. So this is about 180 microns. So as we get farther and farther away from the vessel, the level of oxygen decrease significantly. And that's kind of shown here when you look at the PO2, or the partial pressure of oxygen in the tissue. In addition, since some of these vessels kind of loop around and they go nowhere, there's very poor blood flow. So this is also another problem because sometimes some regions of the tumor might not even be getting fresh blood. So what happens is as we have a decreased partial pressure of oxygen or oxygen levels in the tumor, we actually have increased resistance to therapy. And overall, in terms of cancer biology, hypoxia results in increased metastasis. We have selection of apoptosis-resistant cells. It actually works to suppress the immune system. And overall, as I said, it relates to poor patient prognosis. So measuring tumor oxygenation is very important, and it might tell us things like how likely it is the patient's going to respond to treatment, and things like if the tumor is more likely to be malignant or metastasize. So traditionally, the methods that have been used to measure tumor oxygenation are very invasive. So some of the more traditional methods are these polygraphic electrodes and fiber optic electrodes, immunohistochemical staining for markers of hypoxia, and measurements of DNA damage. And on the right here is actually, this is an example from a paper in 2005, and this is a polygraphic electrode. So what you're seeing is actually, these are kind of like needles which are inserted into the tumor. And one of the benefits is that using this system, you can actually measure the partial pressure of oxygen and provide actually a direct measurement of the oxygen levels within the tumor. However, as you can probably imagine, there are lots of cons to these kinds of methods. First off, since they're invasive, you're less likely to get patient compliance because you have to go into the tumor to receive samples. They only provide limited spatial information because either you're sticking your needle track or you're sampling just one specific region or only a few select regions within inside the tumor. So you're not getting the full distribution of hypoxia within that tumor. And as a result, this actually makes repeated measurements difficult because you really can't go back in over again to measure the tumor oxygenation. And even more, you can't really go back into the same spot and see what's going on in that same spot over time. So there's really this desire to shift towards non-invasive methods which can measure tumor oxygenation. And as a result, non-invasive imaging techniques actually are some of the best ways to measure tumor oxygenation within tumors. And three of the most common methods are positron emission tomography, or PET, which is actually, it uses radiolabeled tracers which target hypoxic regions. It's very sensitive and it can visualize molecular events. Unfortunately, it uses radioactive tracers and has poor resolution. Computed tomography, or CT, is another technique which has high resolution. And one of the benefits of this technique is that it's used routinely in head and neck cancer patients. However, this requires contrast agents, it's expensive, and also uses ionizing radiation. And finally, MRI, or magnetic resonance imaging, is another imaging technique. And it has benefits over CT and PET because it's non-ionizing and it's very clinically relevant. Unfortunately, MRI is also expensive, it's technically demanding, and some of these imaging techniques actually do require contrast agents. So with this in mind, kind of our interest, and I think what a lot of people are thinking, is that photoacoustic imaging could really be a safe, cheap, and easy alternative to these previous methods for measuring tumor oxygenation. So photoacoustic imaging is based on the photoacoustic effect, which was first described by Alexander Graham Bell in 1881. And what he observed, or what he did actually, is he focused light into a metal receiver, and inside this metal receiver there's actually a selenium cell. And what he observed is that when he focused light onto this receiver in the cell, it actually produced sound in a very basic sense. And subsequent research, essentially over the 1900s, found that essentially when objects absorb light, they undergo a thermal expansion which produces sound waves. So today, we actually can exploit this because there are actually things inside our tissue which will absorb light, undergo a thermal expansion, and produce sound waves. So there are actually commercial systems, one being the Vevo LAZR system, which have a combined ultrasound and laser integrated into one probe, so that you can shine light into tissue, you can have it absorbed by these optical absorbing species that will heat up, and then they will produce the sound waves that can be detected with an ultrasound. So just to kind of break down the basics of how this works. So with a laser, we actually have nanosecond pulse laser pulses. And as this light pulses into the tissue, you actually get optic absorption by these species within the tissue. They undergo a thermoelastic expansion, which produces pressure waves that can be detected acoustically. So now we can actually, using the laser and the ultrasound integrated together, now we can look spatially and understand the distribution of these optical species within the tissue and also determine their concentration. And one of the very nice things about photoacoustic imaging, or I guess one of the nice things about our tissue, is that one of the main optical absorbers is hemoglobin. And specifically, hemoglobin, whether or not it's bound to oxygen, actually has a different absorption profile. So what I mean here is if you look at this pink line here, this is deoxyhemoglobin. You can see that deoxyhemoglobin has a peak at around 750 nanometers, whereas oxyhemoglobin has peaked around 850 nanometers. So what we can do is, by photoacoustic imaging, imaging at these two wavelengths, 750 nanometers and 850 nanometers, we can get an idea of the levels of total hemoglobin by essentially adding these two, the levels of absorption at these two wavelengths together, and the oxygen saturation levels, which is by taking the ratio of the oxyhemoglobin levels to the deoxyhemoglobin levels. So of course, we can actually exploit this to learn things about tumor physiology, and specifically things like tumor oxygenation and hemodynamics. And I just want to give a brief overview of some of the current clinical applications. So there is a lot of interest in using this not only for detection of cancer, but also for distinguishing between malignant and benign lesions. And this is one example where they looked at ex vivo thyroid tissue, and they scanned it with photoacoustic imaging, and they measured the levels of deoxy and oxyhemoglobin levels, and wanted to see if they could kind of separate out benign, normal, and malignant tissue. And what they found is that as the levels of deoxyhemoglobin increased, the probability that it was actually cancer and malignant increased as well, which kind of goes back to that first slide on tumor oxygenation. So essentially, tumors which had or tissue which had lower oxygenation was more likely to be malignant. And then just another paper. So a lot of work has been done in breast cancer. This study compared it to MRI just to see if you could spatially detect lesions within the breast. They did a very nice job lining it up, and also comparing the photoacoustic imaging to staining of vessels, CD31 staining. And then another paper which looked at ex vivo prostate cancer tissue and found findings similar to the first paper, where essentially tissues which had higher deoxyhemoglobin levels, which were more hypoxic, were more likely to be malignant. However, despite all this interest in using photoacoustic imaging for these kinds of measurements, there really has been a lack of validation with standard radiologic techniques. In addition, most of the focus really has been on the diagnostic applications. So whether or not it's differentiating between benign versus malignant lesions, or just for detection to look at where the tumor is in the tissue. So the potential of photoacoustic imaging for monitoring the response of tumors to therapy is relatively unknown. So that's kind of like the second question gap. I'll kind of be on the tail end, and I'll address that later. But just to start, I'll talk about some of the validation studies that we did in our lab. And you can actually find, so these are two papers that we published recently. One was in Radiology, one was in Scientific Reports. So in the first paper, we compared photoacoustic imaging to blood oxygenation level dependent MRI, or BOLD-MRI. So this is an MRI technique which has been used a lot clinically, and most of the applications really have been for functional brain imaging. So the way it works is this MRI technique is actually sensitive to the levels of oxy and deoxyhemoglobin in blood, kind of similar to photoacoustic imaging. So a lot of the studies which have been used for the brain actually involve the use of either showing a patient a stimulus or inducing some kind of stimulus and measuring changes in blood flow or blood oxygenation in the brain. However, in tumors, these studies usually involve the inhalation of a gas, a hyperoxic gas called carbogen, which is 95% oxygen and 5% CO2. And what this does is that as you breathe it in, it actually alters what we call the hemodynamics. So it actually increases blood oxygenation, and the CO2 actually induces something called hypercapnia, which actually induces increased blood flow. And this technique, BOLD-MRI, is what we call a T2-weighted technique. But the most important thing is essentially, so as you inhale this carbogen gas, you should decrease your levels of deoxyhemoglobin, increasing your oxyhemoglobin, and you'll expect to see increases in your T2-weighted signal. The second technique is oxygen-enhanced MRI, and this is a more relatively a new technique. It's undergoing a current clinical evaluation, and in contrast to BOLD-MRI, this technique is actually sensitive to the overall concentration of oxygen in tissue. And these studies are very similar to BOLD-MRI, where they usually involve inhalation of 100% oxygen gas to alter hemodynamics. So in here, we're more interested in just increasing the total levels of dissolved oxygen in the blood and tissue. And again, in contrast to BOLD-MRI, this is what we call a T1-weighted imaging technique. So first, I'll talk about the BOLD-MRI experiments, and then I'll talk about the oxygen-enhanced MRI experiments. But just to begin, I wanted to show essentially the setup for the Vevo LAZR system, if any of you aren't familiar, if you've only used the Vevo LAZR system or the Vevo system for ultrasound, this system is comprised of a tunable laser between 680 and 970 nanometers. This laser is coupled to the photoacoustic probe through optical fibers, which are integrated along this ultrasound probe right here at the surface. And just as an example, let's say that we have some kind of tissue that has blood, like a single blood vessel. So we pulse light into this phantom, or this tissue with a single blood vessel. We'll get our sound waves coming back, which will be detected with the ultrasound component of this probe. Then these will be amplified and digitized. And then the Vevo 21 workstation actually will work to reconstruct these images. And what you see here is a pseudo-colorized photoacoustic image on top of ultrasound. So the ultrasound is the gray, what you're seeing here, and the photoacoustic imaging is this kind of red, what you're seeing here. So you can see this is our single blood channel, and we have this kind of signal coming right from there. So for the first validation study, we wanted to see how well can photoacoustic imaging detect changes in tumors following carbogen gas inhalation, and how do they compare to BOLD-MRI. And these studies were performed in SCID mice, so severe combined immunodeficient mice. So these mice are lacking immune systems. And the reason why we did that is actually this way we can take tumors from humans and we can implant them into the mice and they grow without being rejected by the host immune system. So for the first study, we used FADU tumors, which is a cell line of head and neck cancer, which is used commonly. And we implanted 10 mice onto the flank of the mice, as you see here. And then we allowed the tumors to grow for 3 weeks to they're around 75 to 100 millimeters cubed. And at this point, we performed our baseline photoacoustic imaging and BOLD-MRI. So for the photoacoustic imaging, we allowed them to breathe room air for 2 to 4 minutes, and then we switched them to the carbogen gas and acquired images for 6 to 8 minutes afterwards. In between photoacoustic imaging and BOLD, we let them recover for about 15 minutes, and then we re-anesthetized the animals, and again, we imaged for about 4 minutes during air breathing, and then 8 minutes during carbogen breathing. Then, actually, as a second step in this study, we actually used something called a vascular disrupting agent, or a VDA, because we wanted to induce a vascular shutdown. So we wanted to induce changes to the vessels and see if we could detect that with both imaging techniques. You'll see here that actually for this treatment we only have 8 mice, so we lost 2 mice, and that was unfortunate, I think, because we only had 15-minute break between these 2 imaging periods, so we imaged probably for an hour to an hour and a half straight, and we lost a couple animals. So unfortunately we only had 8 mice to finish the study. However, after we treated those 8 mice, we repeated the experiment with photoacoustic imaging and BOLD-MRI and imaged during air and carbogen breathing. And after this last imaging session, we extracted measurements in the form of oxygen saturation measurements, so SO2, which again is that ratio of the 850 of the oxyhemoglobin to 750 deoxyhemoglobin. And then also compared it to BOLD-MRI signal, which is the T2 weighted signal intensity, which we have normalized to an external phantom. And just getting into what we saw from the study, what you're looking at here on the left, so on the top, this is our photoacoustic image of the FADU tumor. So as you can see, the gray, again, this is the ultrasound component that you're seeing, which is the gray. And this color map, this blue-red color map that you're seeing is pseudo-colorized oxygen saturation levels, where red means very high oxygen saturation and blue means low oxygen saturation. So what you immediately see is that when we went from air to carbogen, we had a very strong increase in levels of oxygenated or high oxygen saturation levels compared to pre-air or pre-carbogen breathing. When we looked at our BOLD-MRI images, and again, so this is a pseudo-colorized BOLD signal map on top of just a grayscale MRI image, you can see that similar to what we saw in the photoacoustic image is that following carbogen inhalation, we saw these increases in red inside the tumor, which are indicative of higher BOLD signal. And on the right here, this is just the quantification of these all 10 mice that we were imaged before treatment. And what we saw was very interesting. So with both techniques, we saw a significant increase in levels of oxygen saturation and BOLD signal. what you will observe is that while some tumors seemed that they increased a lot, we also had tumors which kind of stayed the same and some that went down, which indicates to us that so there is some degree of heterogeneity between these tumors, which is kind of expected because not every tumor is going to be exactly the same. So this just shows us that photoacoustic imaging is capable of telling us, okay, some tumors have very functional vessels, and some tumors maybe the vessels aren't working at all. And when we compared the change in photoacoustic imaging signal, the oxygen saturation levels, to the change in BOLD signal, we saw there was a nice significant correlation between the change measured with both techniques. And finally, we wanted to compare the enhancements. So we wanted to see the relative % increase in signal for our photoacoustic imaging versus BOLD-MRI. So essentially trying to see like how sensitive is photoacoustic imaging to these changes in oxygen following carbogen inhalation. And what was very interesting to see is that photoacoustic imaging showed almost a 30% increase, whereas BOLD-MRI was around 8% increase. So we definitely had a considerably higher enhancement with photoacoustic imaging compared to BOLD-MRI. So moving into the second aspect of the study, where we wanted to see could we induce some kind of vascular changes with our drug, and could photoacoustic imaging and BOLD-MRI detect these changes? So what we're seeing here actually in the top left, this is a single tumor at baseline before treatment. And again, this is a pseudocolorized oxygen saturation map on V-mode image. And outlined in white here is the tumor, and outlined in black is some non-tumor tissue that's beneath the tumor. And what we're showing is that looking at the dynamic changes in oxygen saturation levels in the tumor essentially during those 6 to 8 minutes of carbogen breathing. So you can see that within 15 seconds after carbogen inhalation, we were able to detect changes or increases in oxygen saturation within the tumor. And these changes kind of kept going, or they were sustained at 2 minutes and 6 minutes post-carbogen breathing. And then below, this is the quantitation looking at the oxygen saturation levels and showing for each frame, and each frame is around 1 second. So essentially this is, these are frames or seconds. So you can see that almost within 15 seconds we saw this increase not only in the tumor but in our non-tumor. However, when we treated these tumors, you can immediately see that at 24 hours post our vascular disrupting agent that we had a reduction in pre-carbogen levels inside the tumor. So especially this right lobe right here, you can see that a lot of that signal that we had is now gone, which might indicate that there was some kind of vascular disruption or vascular changes inside that tumor, so that now we are not actually seeing any blood flow in that region. And again, we repeated where we imaged with, for 8 minutes and looked at 15 seconds, 2 minutes, and 6 minutes post-carbogen. And what was very interesting is that this non-tumor region right here, we still saw our enhancement, same as baseline. However, in our tumor now, you can see that essentially there was very little to no enhancement inside the tumor. So this just tells us that there was a very specific anti-tumor effect of this drug, and that there was no effect in the normal tissue, which indicates to us that photoacoustic imaging can detect treatment-induced changes in tumor oxygenation. And then we just wanted to see, so what was the overall trend for all of these 8 tumors that we did treat? What was the response like at 24 hours post-EPC when we gave them carbogen? And what we saw is that photoacoustic imaging, we saw a significant reduction in the change in oxygen saturation levels following carbogen inhalation, same as that tumor that I just showed you. And then when we looked at BOLD-MRI, we saw the same thing. It actually was more significant. But what was interesting is we actually saw some negative changes in BOLD signal, which might be due to some of the mechanisms of how BOLD signal, how we obtain BOLD signal, because BOLD actually is very susceptible to things like blood flow and hypoxia levels within the tumor. So maybe by inducing some hemorrhaging or disrupting blood flow, maybe we saw some weird things going on. And then we wanted to correlate our photoacoustic imaging to BOLD-MRI, and we actually did not see a correlation, which was interesting. So, but overall, what we wanted to conclude is that photoacoustic imaging can detect these treatment-induced changes in tumor oxygenation. So for the second study, we wanted to move into our oxygen-enhanced imaging. And what we did in this study, we actually used tumors that we got from the clinic. So we actually get patient samples, head and neck cancer patient samples. And again, we put these samples into immunocompromised mice, and then we actually passage the tumor in mice. So we allow the tumor to grow in the mouse, and then after 2 to 3 passages, we use them for studies. So these tumors were implanted onto the flanks of SCID mice, and again, we let the tumors grow for about 3 weeks. And in this study, we actually had tumors which were around 300 to 500 cubic millimeters. So this tumor is very aggressive. It grows very large in a short period of time, which is good because we were actually interested in seeing can we detect some heterogeneity of oxygenation within kind of larger tumors, not small ones. And similar to the BOLD studies, we performed our photoacoustic imaging during air, and then this time we gave oxygen. So we did 2 to 4 minutes of air breathing, and then around 6 to 8 minutes of oxygen breathing. And then for oxygen-enhanced MRI, we again acquired images for about 4 to 5 minutes during air breathing, and again 5 to 6 minutes during oxygen breathing. And in this study, we didn't treat them with anything, so we actually extracted our data in the form of oxygen saturation measurements, and in this, for oxygen-enhanced MRI, we're looking at R1 levels. And then we also removed the tumors, and we fixed them in formalin, and we stained for hematoxylin and eosin to look at the levels of, or the degree of heterogeneity in terms of tissue viability. And the ultimate goal of this study was we wanted to co-register our photoacoustic images with our MRI and our staining, our H&E staining. And right off the bat, we see that a result very similar to our BOLD and PA studies. So what you're seeing here, this is just the grayscale ultrasound image of the tumor. And again, here's our pseudo-colorized oxygen saturation map on top of our B-mode ultrasound image. And when we switched from pre-oxygen to oxygen, you can see that we had very strong enhancement, especially on the left side of this tumor, whereas we really didn't see a lot of signal on the right side to begin with. When we looked at our oxygen-enhanced MRI, this is a T2 weighted image of the tumor that you're seeing in grayscale. And usually, so what's interesting here is if you look at this image, I hope that you all can see, on the right side, you can see that this right side is a lot brighter than the left side. And usually on a T2 weighted image, areas where you have kind of like free water, you see they tend to be a little bit brighter on a T2 weighted images. So this kind of indicated to us right off the bat that maybe there was some kind of necrosis. So if we had some like free water or a lot of dead cells, we might expect to see some brighter signal on our T2 weighted images. And again, what was interesting is that if you look at, this is a pseudo-colorized R1 image on top of this grayscale image. You can see that when we switched to oxygen, this left side of the tumor enhanced a lot. And on the right side, we essentially saw very little change. So this indicated that there is some heterogeneity within these tumors, and we were able to see it on both the photoacoustic imaging and oxygen-enhanced MRI. And we looked at individual tumors. We once again saw that there was a very heterogeneous response to oxygen inhalation. So with photoacoustic imaging, we saw some tumors which increased a lot and others which didn't increase or actually went down. And we saw the same thing with oxygen-enhanced MRI. And we also correlated this, these two readouts, so looking at the change in oxygen saturation levels with the change in R1. And this time, although it wasn't as significant as the comparison between photoacoustic imaging and BOLD-MRI, we again saw there was a strong, positive correlation between the change in oxygen saturation levels and the change in R1 measured with both techniques. But what was really interesting in this study actually is if we look at the relative percent enhancement, so the percent change in signal following oxygen inhalation, now we saw that photoacoustic imaging was significantly higher than oxygen-enhanced MRI. Once again, indicating that photoacoustic imaging is very sensitive to these changes in tumor oxygenation following either carbogen or oxygen inhalation. So moving into the second part, so we removed the tumors in this study and we stained them for H&Es, and we wanted to see if we could kind of detect some spatial heterogeneity in terms of the tumor viability and where we were seeing signal on our photoacoustic imaging and oxygen-enhanced MRI. And this tumor, this is the same one that I showed the images for the MRI and the photoacoustic imaging. But now when we add in the H&E, what you see is that the left side of the tumor was very viable. However, the right side was very necrotic. So it lined up with our grayscale T2 weighted MRI image. And we also see here that the necrosis was kind of isolated to the right side of the tumor, whereas left side was pretty viable. And then just as another example, we looked at one tumor where essentially there was no change on the oxygen-enhanced MRI images, and then there was no change on the photoacoustic images. And when we looked at the H&E, we can see that the tumor was essentially all necrotic. So just telling us or revealing to us that photoacoustic imaging can not only detect heterogeneity between tumors, so comparing these two tumors, showing that one tumor enhanced a lot and one tumor enhanced only a little bit, it can also show us inter-tumor heterogeneity. So within this tumor, looking at, okay, the left side was very viable and had lost oxygen, whereas the right side was necrotic and we didn't see any signal at all. And then we also want to compare spatially our oxygen-enhanced MRI and photoacoustic images to see if there was spatial agreement between them. So areas that showed strong R1 signal or photoacoustic oxygen saturation levels, did those actually line up between the two imaging modalities? And to do this, we actually loaded them into another analysis software called Analyze, and we were able to kind of align our images together. And once we had them aligned, we traced this region of interest around the tumor, and then we divided that into 9 subregions. And then we wanted to compare each subregion to see, okay, do these subregions match up together, or do they not match up? And what was very interesting is that when we looked at the post-oxygen levels of oxygen saturation and R1, we saw a very nice correlation between the two methods, showing us that there was significant spatial correlation between the two imaging techniques. So just in conclusion, so in both our BOLD and oxygen-enhanced MRI validation studies, we saw that photoacoustic imaging was very sensitive to changes in oxygenation, more so than both BOLD and oxygen-enhanced MRI. In our photoacoustic and BOLD studies, we did see a significant correlation between the two imaging techniques. When we treated the tumors with our vascular disrupting agents, photoacoustic imaging was able to detect some kind of functional changes in the tumor oxygenation, not only before carbogen breathing, but after carbogen breathing. Then when we compared to our histology, we saw that we were able to detect the inter- and intra-tumoral heterogeneity and tumor oxygenation. And finally, we were able to detect, or we saw a very good correlation between the spatial heterogeneity observed with our photoacoustic oxygen saturation images and our oxygen-enhanced MRI R1 images. So, and then this is getting into more kind of the overall goal of what my research is looking at, is that we want to answer the question, so now that we kind of validated the oxygen saturation levels with these two MRI techniques, can we use these measurements to kind of predict tumor response to therapy, and specifically radiation therapy is what we're interested in. And as in my background, as Christina suggested, we are focused on head and neck cancers. And head and neck cancers are a diverse group of cancers that affect multiple sites within the head and neck region, ranging from the oral cavity to the pharynx, larynx, salivary glands, and the sinuses. And as many of you know, the primary risk factors of head and neck cancer involve tobacco and alcohol use, and more recently HPV infection has also been implicated as a risk factor. And the majority of these cancers develop in the epithelial cells, which line these kind of these surfaces, mucosal surfaces in the head and neck regions, and they're therefore referred to as head and neck squamous cell carcinomas. And standard of care is usually a combination of surgery, radiation therapy, and chemotherapy. So for early stage, usually it's surgery or radiation therapy given alone, or for later stage, it's usually a combination of all three. So radiation is really an integral part of the treatment paradigm for these patients. So what's really interesting about this is a lot of people have done research to kind of figure out factors which influence or impact radiation efficacy. And probably the most research has been done on looking at how tumor oxygenation actually impacts radiation response. And just as an example, this is a paper from the late 70s where they looked at 28 patients with advanced stage non-metastatic head and neck cancer. And these patients were going to be getting radiation plus or minus surgery. And they used the invasive polyographic electrode. They inserted it into the tumor, and they obtained the partial pressure of oxygen, or PO2 measurements, to measure the distribution of oxygen within the tumors. And then once they did this for all patients, they actually stratified patients by those which were above the median partial pressure or PO2 levels and those which were below it. And this cutoff for them was 10 millimeters of mercury. And what we saw, or what they saw, I should say, is that patients which were below the median, or less than 10 millimeters of mercury, not only had a worse disease-free survival, but had a worse overall survival compared to those which were above. And there have been several studies which have looked at this and kind of confirmed these findings. And what this tells us is that there is clinical value in measuring tumor oxygenation levels in head and neck cancer patients. The only problem is that, as with the first study, the majority of these studies are carried out using these invasive PO2 measurements, or these ex vivo kind of staining for markers of hypoxia. So there's really a call for non-invasive imaging techniques or non-invasive techniques which can measure tumor oxygenation and maybe predict response to therapy. So just to share with you, this is the study that we presented in the scientific reports paper. And this study was, again, performed in immunocompromised mice, and these mice were bearing patient-derived xenografts. The tumors were implanted and allowed to grow to 350 cubic millimeters. And once they reached the size, we performed baseline photoacoustic imaging, so before any kind of treatment. And then we also treated them with a single-dose radiation or a combination of cetuximab and radiation, which is our chemoradiation group. And just so you know, the chemoradiation was given, the cetuximab was given immediately after this baseline photoacoustic imaging. Radiation was given 25 hours after baseline imaging, and then after that, 24 hours after radiation, we repeated the photoacoustic imaging to see if there were any changes in tumor oxygenation and if that information had any value as well. And during this time period, we actually acquired ultrasound volumes of the tumors for every 3 days until 14 days, or about 2 weeks after completion of radiation. And what was really interesting to us is that we actually saw what we call a heterogeneous response. And what I mean is that we actually had some tumors, in this case M1, which showed an increase in oxygen saturation levels following radiation. And we had other tumors which went down following radiation. And we observed this for both our single-dose radiation group, so this 15 grays of radiation, and our combination cetuximab radiation group. We also saw very similar things. So again, this just shows us that photoacoustic imaging can also tell us kind of heterogeneous responses to treatments, and also heterogeneity within the tumors before treatment. Unfortunately, when we looked at the percent change in volume from the pre-treatment to 2 weeks after treatment and the baseline oxygen saturation levels, we did not see a correlation. But what was really interesting is that when we looked at the change in oxygen saturation levels following radiation, tumors which actually increased in oxygen saturation levels following radiation had a markedly favorable response compared to those which decreased, which says to us that maybe there is some value as well, also measuring the change in oxygenation and not just measuring the pre-treatment oxygen levels. And when we looked in the literature, we actually found a paper which showed some similar results. And this is in advanced stage head and neck cancer patients who were receiving chemoradiation therapy. In this study, they actually imaged before treatment and 2 weeks after treatment. But what they saw is that patients which had, and this, I'm sorry, this is MRI that we're seeing. This is dynamic contrast enhanced MRI. So these are blood volume maps, which is an indication of how much blood is inside the tumor. And we saw that they saw that two patients which had an increase in blood volume following treatment actually had local control, versus tumors which went down or stayed the same actually had local failure. So there is some clinical evidence which supports our findings. So we're very interested in kind of following up these studies and seeing if we can repeat these. So we'll see in the future. But anyways, to conclude this part, so unfortunately we saw that pre-treatment oxygenation levels did not correlate with tumor response in our patient-derived xenograft head and neck cancer model. And again, so this is not completely discouraging because we only gave them 1 dose of radiation. It was a kind of a high dose, and also with our PDX model, it's an immunocompromised model, so most patients have a are not immunocompromised. So maybe there's some things that we have to look into for future studies. But what was interesting is that when we looked at the change in oxygen saturation levels following treatment, we did see that there was a correlation between response and increases in oxygen saturation. And what this tells us is that there is potential for monitoring tumor oxygenation throughout radiation and chemoradiation therapy. This might help us identify patients who are unlikely to respond to therapy. And just for some of the significance and clinical implications, so not only before treatment can we identify patients which might benefit from treatments which will modify hypoxia or target hypoxia, but we can also use photoacoustic imaging for radiation treatment planning, so maybe adapting the radiation dose based on whether or not where the areas of hypoxia are within the tumor versus areas which are well oxygenated. And then again, finally, early identification of treatment failure in some of these patients, which might help avoid some unwanted side effects or ineffective treatments, and then allow them to be switched onto other therapies which might be more effective. So with that, I'd just like to acknowledge my mentor, Dr. Mukund Seshadri here on the left. This is a lab photo from a few years ago. I'd like to thank the Translational Imaging Shared Resource, or TASER. The lead of that is Dr. Joseph Spurniak. Obviously, so all this imaging was done at Roswell Park Cancer Institute, and it was all performed through funding through these various agencies. So thank you for your attention, and I'd be happy to take any questions if you have any.
On behalf of everyone, I'd really like to thank Laurie very much for your very interesting presentation. So at this time, we'll get into some questions. We already had a couple roll in here, but in case you did have any questions, if you look on your right-hand panel, you'll see a questions tab. You just have to expand that tab, and you can pose your questions there, and we'll head them straight to Laurie. So while people start asking their questions, I'll start with one here. Did you ever consider normalizing your SO2 measurements by tumor volume? And maybe an explanation as to why or why not.
I should have actually, I'm sorry, I didn't really go over how we perform these measurements. But the way that we perform these measurements is we actually draw a 3D region of interest for the whole tumor. And the readout that we're showing here is SO2 total, essentially is a measurement which accounts for the total volume of the tumor. So it's it looks at the levels of oxygen saturation for the whole tumor. So basically, if you have a really large tumor with really high signal, or a really small tumor with really high signal, you'll get the same measurement. So, or versus like if you have a large tumor with not a lot of signal, or a small tumor with no signal. So I guess that's kind of confusing, but the measurement that we make actually does account for the size of the tumor.
Okay, great, thank you. So another question came in about sensitivity. So how does the sensitivity compare with photoacoustics versus BOLD-MRI? And kind of a follow-up to that, carbogen changes hemodynamics as well as the actual SO2. So how do you separate these effects from each other?
Yeah, so that's a really great question. And so, I mean, the problem is, so both techniques are, so even though BOLD-MRI is dependent on the levels of deoxy and oxyhemoglobin, it's completely different than photoacoustic imaging, obviously, because BOLD-MRI is also dependent on magnetic properties of tissue, which can be influenced by things like blood flow or the degree of hypoxia within the tumor, or even dissolved oxygen levels can affect that. And photoacoustic imaging is more of a direct readout of the oxygen saturation levels. So I think maybe in some senses that's why photoacoustic imaging in these studies, we saw a little bit higher sensitivity, because we're directly measuring the levels of oxy and deoxyhemoglobin, and we're not kind of susceptible to some of these other things that MRI could be. And then for the second, what was the second question? I'm sorry.
So it was that carbogen changes hemodynamics as well as the actual SO2. So how would you separate these effects from each other?
Right, and so that's a great, so yeah, so this is so when you give animals these gases, like, so if you give pure oxygen to animals, it actually has vasoconstrictive effects, so it could potentially decrease blood flow. And carbogen as well, because so carbogen is a little bit higher CO2, so some people actually say they might increase, it causes hypercapnia, which could increase blood flow. So there are those two things that are coupled together. Yeah, it's a really good question. I'm not sure how exactly we would be able to separate out the two different effects. Yeah, that's a great question. That might be one that Dr. Seshadri would actually be able to answer if you're interested in asking him. But Yeah, so we are definitely aware, though, that there are some other effects that, so the gas inhalation is not just changing oxygenation in the blood, but could be changing blood flow. So those are definitely things that need to be accounted for.
Great, thanks, Laurie. So a couple of times this has come up. What is the depth of photoacoustic imaging, and what's the sensitivity at depth?
Right. So unfortunately, I didn't present all my thesis work, but the whole first aim of my thesis work was looking at essentially kind of using the Vevo LAZR system and what's our maximum imaging depth and kind of what's our signal-to-noise ratio limit. So with the probe that we're using right now that I used for all these studies, we were able to attain signal-to-noise levels above 5, which is kind of like a cutoff of, okay, what is actually, how confident are we that this is real signal, up to 1.2 centimeters per blood. So in most of these tumors, most of the tumors weren't even below 1 centimeter, so we should be good with that. We've also investigated some other, looking at different imaging frequencies, which actually improved the overall imaging depth. And kind of the best imaging depth that we've been able to obtain with the system is up to 2.7 centimeters. So we're talking almost 3 centimeters, which is pretty good, actually, especially if we're talking about head and neck cancers. There are some very superficial lymph nodes that we might be able to image with photoacoustic imaging.
Great, thank you for that. So just another question that came in. You noticed you compared percent SO2 with photoacoustics with DC MRI for flow and perfusion. Did you try using power Doppler flow for photoacoustic ultrasound technique with the laser, and or something like contrast infusion of microbubbles?
Okay, yeah, so that's great. And so for the power Doppler question, so we actually unfortunately didn't get power Doppler until after these studies were performed. So in the future, and this might actually answer some of those questions about, okay, like what is the effect of the gas having on like blood flow? How can we separate out those effects? So maybe using Doppler we can see, okay, what were the changes in like blood flow and how do those compare to the changes in oxygen saturation levels? So for these studies we didn't have that. But if you go to the radiology paper from 2015, we actually did compare to contrast-enhanced ultrasound. And again, we did our photoacoustic and contrast-enhanced ultrasound before and after treatment with our VDA. And what was really nice to see is that spatially we saw a good agreement between the two imaging techniques, which you would hope. And then after treatment, we again saw that areas which kind of lost signal with photoacoustic imaging also changed with our contrast-enhanced ultrasound. So we did kind of validate with that. That's in the supplementary figures of that paper, but that was just a small study where we compared, but we did see some nice spatial correlation between those two methods.
Thanks, Laurie. Another audience member complimented you and said, excellent presentation, thank you. You explained very clearly the spatial variability of tumor oxygenation. However, there is evidence that there is also temporal variability. This temporal variability involves a long time scale as the tumor grows, but also a cyclic short-term variability that is on the time scale of tens of minutes. Do you think this might explain the variability in the radiotherapy study?
Yeah, so that's a great question. And so again, so going back to that first slide on hypoxia, so it's not just like the hypoxia is not just a result from the inability of oxygen to diffuse only a certain amount from the vessel, but from these kind of perfusion changes inside the tumor, which are very dynamic. So some areas could go from being oxygenated to not being oxygenated in like in a few minutes. So actually, that's one interesting thing. So in the first BOLD versus PAI study, we saw a nice correlation between the two imaging techniques, and we imaged within 15 minutes of the two techniques. In the second study, we actually waited 3 hours because we lost 2 mice in the first study. So we actually waited, and then you see in that study, we actually didn't get a significant correlation between the two techniques. So that's kind of one of the interesting things. So we're not sure how these kind of intermittent changes in tumor perfusion could actually affect these readouts. And so not only for the radiation, but like comparison studies, you know, what is going on in the tumor? What is going on in the tumor when you're imaging with photoacoustic imaging could be different than what's going on with your BOLD or oxygen-enhanced MRI. In terms of the radiation, again, it's a good question because so we actually performed imaging 24 hours before we actually gave the radiation. So it is possible that there were changes, and one of the things that might be interesting to do is kind of image immediately before. So unfortunately, our radiation system and the Vevo system are not in the same room. But what would be excellent is if we could actually image the tumors, let's say like right before we gave them radiation or even during radiation to see exactly what's going on. And those measurements might actually improve our correlation in terms of the baseline measurements versus the radiation response. So yeah, great question. That's definitely something that we've thought about.
Thanks, Laurie. We actually have our product manager, Drew Heimler, here, and he suggested you can actually image for tens of minutes and actually just visibly watch and see if you're seeing any difference.
Oh, you're saying just like, yeah, I mean, that's another thing, yeah. So just imaging over 10 minutes just to see what's the fluctuation. Yeah, absolutely. And I'm sure you'll see some areas of the tumor which, were well oxygenated, changing, maybe not even being oxygenated at all, or some areas that maybe show up, So that would be a very interesting study to perform.
So we've had a couple of questions about clinical relevance. So clinical relevance in the future. What can be measured in humans using photoacoustics, and how do you see this technology being implemented in the future?
So I definitely believe that in head and neck cancers, and it might, with advances in the hardware or software, or maybe like the ways that we calculate oxygen saturation, we probably will be able to improve imaging depth beyond 3 centimeters, hopefully. I mean, some people have reported pretty deep, like beyond 5 or 6 centimeters. So we'll have to see what happens. But in terms of even our system getting up to around 3 centimeters, I think that for a lot of for head and neck cancer patients, especially those with disease in the neck, kind of nodal diseases or more superficial lesions, I think that 3 centimeters is probably a decent range. I think that even now we probably could perform some studies. So I definitely think clinical relevance, I think that we're almost there. And I think these preclinical studies are just nice proof of concept, but really where it's going to show us, I think the true benefit will be actually in patients. And again, so these models that we're using are immunocompromised animals. They're not fully immunocompetent like humans would be. So it'd be interesting to see, it might actually work better in humans than some of these preclinical models that we're using.
Great. So another question, using photoacoustic imaging, what was the time scale of detection of time to radiation treatment failure? So this would speak to the ability to quickly determine when a treatment is not working.
Yeah, so that's, these are all great questions. So this question would be interesting. So for us, I mean, based on our findings, we saw that within 24 hours, so the change in oxygen at 24 hours was an indicator of response at 2 weeks after treatment. So of course, that's 2 weeks after treatment. Following up for long term would be really interesting. And also the radiation dose that we gave was just a single dose of radiation, either 15 gray or 7.5 gray. Just for those who don't know, in head and neck cancer patients, it's usually given as what we call fractionated radiation therapy, which is given as multiple small doses over 6 to 7 weeks, so about 2 grays a day times 5 days a week times 6 or 7, so to a total of 60 to 70. So for me, what I think would be very interesting is that doing fractionated radiation to some of these tumors and maybe imaging over multiple weeks, just seeing what's going on in the tumor, and then finally looking at how that affected outcome. Because most of these tumors and these studies that we did actually went on to recur, and in fact, none of them shrank, most of them grew. So we really didn't get a full response out of these tumors. So I think that we could answer that question by increasing the treatment, making it more clinically relevant, and then increasing the number of times that we're imaging, so maybe doing multiple imaging sessions during the week, and that will actually help us identify, okay, when is the best time point, what was the most important time point for figuring out when this tumor stopped responding or didn't respond.
Hey, Laurie, it's Drew here.
Hey, Drew.
There's another great presentation, by the way. There's another question about how much of the mouse did you need to shave or remove the hair from for successful imaging?
So when we first shaved the mice just using an electronic shaver, and then we usually apply Nair to a good region, probably like at least half a centimeter to a centimeter around the tumor. And we also do this the day before we do imaging because we don't want to affect. So if you Nair the animals right before you do the imaging, it is possible that maybe that could affect, that could cause some kind of hemodynamic changes in the skin surface or things like that. So we do around about 0.5 to 1 centimeters around the tumor, including over the surface of the tumor, and we usually do it a day before we do the actual imaging session.
Great, thanks, Laurie. But you didn't need to shave the whole animal.
Oh no, absolutely not. No, just over the just around the tumor. Yep.
Thanks.
Yep.
So another question that came in the scientific reports study that you mentioned, what was the tumor size the day of radiotherapy?
Oh, those were 350 to 500 cubic millimeters. Those were big ones. Actually, most of them were around 350 cubic millimeters, but those were big tumors again. Because after the first study, we kind of were more interested in looking at kind of tumors which were larger, were more likely to have hypoxic regions inside of them. So we wanted to stick with something a little bit larger. But we did have a good distribution. We had tumors probably ranging from like 200 to 600, so there was a pretty decent spread.
Great. And with reference to the radiology and scientific reports papers, the audience member comments that we cannot find the correlation graphs between SO2 and MRI parameters that you showed. Example
yes.
On slide 19, if you could just comment on that.
Yeah, so that was done 2 or 3 years ago. So this is the beauty of having being in a dissertation and having a committee. So that was actually feedback from my committee after we had already sent the papers out. So we actually do not have those correlation graphs in either of those papers. So that was all done after the fact, I'm sorry. But they should be on this webinar from now on, so.
Great. Maybe one final question because we're running out of time here. More broadly, what other features and structures do you know of that can be detected with photoacoustics, and any specific other clinical applications you see this type of imaging modality applicable for?
Well, I think the first thing that comes to mind is breast cancer. It's a great imaging modality for breast cancer, and that's because the breasts are very fatty. So like when you have tumors, one of the first things they do in order to grow beyond a couple millimeters, they actually have to recruit and build new blood vessels. So in this kind of fatty breast tissue, when you have increased angiogenesis in these tumors, it's very easy to spot them. And that paper that I think was on one of the first slides I showed, the Heichblom paper, they did a really great job of showing that, okay, they looked at MRI, looked at histology, and showed that photoacoustic imaging was able to very accurately detect kind of the regions of the borders of or I should say the margins of the tumor. So I think breast cancer is great. There's a lot of studies looking at like in prostate, thyroid, cervical, melanoma. I think there are a lot of sites that we're going to see some really good benefit, but breast cancer especially, I think it's going to be great. And I think that with head and neck cancer as well, since there's so much known about the radiation response to these tumors and how oxygen impacts it, I think that photoacoustic imaging really has a lot of potential for head and neck cancer patients.
Great, thanks, Laurie. I think I speak on everyone's behalf here for thanking you on your presentation, your excellent job on answering the questions, and I'm sure everyone would agree that you're going to do a great job on your defense next week, and I think we've all helped you prep a little bit here. I also wanted to thank our audience members and remind you that we have been recording this webinar, and we will be posting it on our website, and it will also be emailed out to you. So thank you for joining us today, and please keep track of our webinar schedule and join us for next time. Thank you very much.